Hi, welcome to the NCS podcast. This is our Perspective subseries. I am your host, Nicholas Morris from the University of Maryland Shock Trauma Hospital. And I have the absolute pleasure here today of meeting with Mary Guanci. Mary is really a legend in the field. She is the former nurse director of the Neurocritical Care Unit at Mass General Hospital, where she helped establish one of the very first units along with Dr. Alan Roper and Dr. Sean Kennedy. In doing so, she helped train a huge number of both neurocritical care nurses and fellows and helped establish both institutional and national guidelines, protocols, and standards in the field. She has served as the president of the American Association of Neuroscience Nursing, a national nursing association with over 5,000 members with specialty in neuroscience. And we're so lucky to have her here on the podcast today. Mary, welcome, and thanks for joining us.
Thanks, Nick, for asking me.
As we've been exploring in this podcast, we really want to get sort of to the origins of neurocritical care and how it all started. And you were really there, from day one almost in the neuro ICU, getting things started at MGH. And so, how did you get involved and what got you excited about the job?
Mm-hmm. So, Nick, I think I'll just take you back a little bit. I didn't start in the neuro ICU. I actually graduated from a BSN program in 1977, and I went to a neuro floor. And the reason I went to a neuro floor was, like all of us, we probably had an experience that led us to neuro. So from the very beginning, I knew I wanted neuro because of a patient experience that happened during my clinical time, and which it was a cardiac patient who overnight, when we weren't there, had an event, a neuro event, and ended up dying, which really left an imprint on me in terms of, did I miss something? Was there something else I could have done? And then, wow, what happens in the brain when people are sick elsewhere? So I really started to understand the importance of the brain. So that led me into neuro at MGH, which I knew had an established neuroscience program there. I worked on a floor where I sort of learned how to work on a team. I met people like C. Miller Fisher and Ray Adams. It was their heyday, and they rounded, and we learned about neuroassessment without the aid of a CAT scan, which was not working when I arrived. So a quick little story. I remember I always tell this story because I was so enthralled by it. But C. Miller, who was known for his exam and diagnosing from exam, when the CAT scan was coming, I was excited. And I said, "Oh, Dr. Fisher, isn't it great? We're going to have a CAT scan. This is going to help, figure out what's happening with our patients." And he said, "Miss McKenna, it will be the downfall of neurology. No one will do a good exam." So learning from those people about neuroexam, et cetera, was really a good stepping stone for, making sure that that I was, in a good learning environment. I also had colleagues who taught me how to mobilize a patient. We were mobilizing neuro patients. We had trachs and ventilators on the floor. We had length of stay that was 4 weeks average for our patients, and not certainly the acuity that you see in the ICU. We also had a program that I'm talking up a little bit way back in the day, and it was a 6-week rotation into the neuro ICU that was just being established. And in that 6-week rotation, I got a little bit of an orientation, but we had the original ICU was an intermediate, 8-bed intermediate care, 6-bed ICU. So when we rotated from the floor, we were oriented to the intermediate care, which gave me also the ability to look and see what was happening in the ICU world. And then it also encouraged people who were maybe afraid to go to the ICU to travel or to work in the ICU. So we actually used it as a recruitment tool now that I look back. And based on that, when I went back to the floor, that's how I ended up going back into the ICU. And when I arrived in the ICU, I was a staff nurse. But certainly Sean Kennedy and Alan Roper had just been assigned to be the overseers, I call them, of the ICU, with also Nick Service in neurosurgery. So I was in at the beginning in terms of how it was working out. The challenges for us in nursing then was that it really was a division of teams. And so the neurosurgeons were in the OR all day, 18-hour surgeries, 22-hour surgeries, and not really present for their patients. And then we relied upon Sean and Alan, who were only there for, well, as long as they needed to be, but, 8-hour days or 10-hour days. So the coverage was a little bit different, and that evolved over time. So I was there for the evolution. Myself, after about a year in the ICU, at the same time in nursing, remember there was really the minimal standard for nursing was an RN, like diploma school type of thing. And there were some of us who were coming out of BSM programs that made me eligible for becoming what was called a clinical teacher at the time. So the clinical teacher left, and there were very few to pick from, except maybe 4 of us who had the credentialing. So by default, and by my own little need to explore and to see if I were really interested in teaching and doing some leadership, I became the clinical teacher. And that's how Sean Kennedy, Alan, myself, and the nurse director, which there was a nurse director, came together as a group and sort of tried to move the unit forward.
Got it. Wow, that so much information I'd love to get into it. We haven't talked much about C. Miller Fisher on this podcast, and Alan Roper briefly brought him up because he saw him in many ways as sort of the precursor to the neurointensivist, because he was interested in large stroke. And since you brought him up, can I ask you to give some more reflections on him and what he meant, not just to training young doctors, because we've heard that again and again, but what we haven't heard is how he was involved in training the nursing staff and getting them to appreciate the neurological exam, et cetera. Can you speak more to that?
Yeah, so I will say one of the things that I admire most about the physicians in that time, and I think I listened to Alan's podcast, and I think he did allude to this, the time at the bedside. So the C. Miller Fisher, many a night, I worked day evenings, 5 days a week in nursing at that time. So I had a lot of contact with him because in the evenings, he would spend his time going around the unit, doing his own exams without his team, trying to make a diagnosis. And I remember like in this one story, as a nurse, you had to take off your own orders because it was paper orders and all of those things that way back in the day that we needed to do. And I remember sitting there at the desk kind of taking these orders off, and he sat next to me for, I would say, maybe 45 minutes, just looking and staring at a patient in a geriatric chair across the hall. And at the end of that 45 minutes, and I was leaving to get up, and I knew he was leaving. And I said, "Well, Dr. Fisher, I'm going to go do my rounds. Great to see you." I said, why are you watching her? And he said, "Well, she has Jacob Crutchfeld, maybe." And I was counting the number of startles as nursing was going back and forth around the corridors. So this is like the type of insight and things that you just go, wow, what dedication, number one. Number two, dedication to the patients, sat at the bedside, talked at the bedside, talked to the nursing staff, always instructing about the neuro exam. So I felt particularly lucky in my career to have had him kind of open up a world of how important my exam as a nurse was, a neuro nurse, which we know is the hallmark of neuronursing is
Absolutely.
our exam, how important my exam was. And I carried that through, I have to tell you, through my career, because that became a real big part of any orientation program that I did, was understanding what was different about this patient's exam and what might be different. So it really came from people like him. Also, I have to tell you, like Dr. Ogeman, neurosurgery side, Nick Zervis, a number of those physicians stayed at the bedside, spent a lot of time with nursing at the bedside, just answering questions or doing whatever. So, he had a quiet presence, I will say. I don't think I ever saw him raise his voice, anything like that. So just his quiet, presence was also appreciated.
That's interesting. I haven't heard people describe him as quiet, but his impact lasts this day. I mean, you can't talk to anyone who's trained at Mass General Hospital without them bringing up C. Miller Fisher. I was lucky enough that I think I picked up on some of those teachings through his successors, which I really enjoyed. Can you take me back to when you were then in this clinical nursing, this teaching role? What did you focus on in the early days in kind of transitioning neuroscience nurses to neurocritical care? Because there's a big jump there.
Yeah. And remember, there were some nurses there who had critical care experience already when I got there. So the biggest challenges, I think, was just the dynamic impact of having a new place where I want to say you could play. And certainly neurosurge and neurology was all over the fact that we had now our own ICU area. And we had, nursing staff dedicated to these patients and those types of things. And the ideas that were coming about treatment and care were just ongoing. Like, think about the evolution of stroke care. We used to see, what we used to call stroke and evolution, where a stroke patient would come in and we just see them lose function in front of us. So we had these stroke guidelines that were being developed. We had, things like subarachnoid hemorrhage changing. We had Phil Kissler, who was another neurologist at MGH, who sat at the bedside 24/7 and wrote down blood pressures and exams. So, I mean, things were so dynamic and happening that when I had to look at what we could bring to the table in terms of nursing, we talked about the neuro exam, but the neuro exam and nursing go hand in hand. The importance of nursing is getting to know your patient, getting to know what exam changes were, getting to anticipate what might be the first sign of a problem or even an improvement in your patient. So I really concentrated on like a better neuro exam, a neuro exam based on diagnosis or a suspected diagnosis, what to expect, and then the emergency pieces at the beginning. And then we expanded from there. The hard part for me was, people's needs to want to do and create, different pathways or research protocols, which always involved nursing care. And so how do you, delineate what's the most important, what should we do, prioritize, and those types of things. So the conversation and the relationship between Sean Allen, the nurse director, who had many nurse directors, but Diane McKenna and myself, like those dynamics were really in play in terms of like, what's the priority here for nursing. So
got it. I remember from my time as a resident there, it felt to me like the nurses were in charge and they were empowered to do that, right? And to tell us what the patient needed and to speak up. And how did you develop that culture in the ICU there? And how would you recommend that we do it now when I think sometimes nurses are feeling less empowered than ever because of all of the oversight that they have?
Well, one thing is knowledge is power. So, when you look at nursing and nursing role, majority female, family outside, other priorities as well. I think that in my role, it was really to help facilitate learning. So what was important about the neuro exam and the disease process? Let's focus on that. We did rounding at the bedside every day. Change of shift report, we rounded. I did singular rounds on patients and talked about what were the nursing priorities for that patient. We provided education. I think Sean and Alan and I developed a sort of I don't know what to call it these days, but it was like a small conference, a mini conference, where we tried to just keep them updated, because I believe knowledge is power. So you empower someone by, not keeping secrets and really keeping them up to date in terms of what's coming. The other thing was, we really empowered them to have a voice because we let them, or we encourage them to attend any type of meeting. So our, staff meetings, we had meetings with the neuro residency. We developed along the way a clinical science committee or procedure committee or practice committee that nurses sat on in the unit. The hospital itself isn't empowering, like it really tries to empower nurses through using their voice. So they're involved as a hospital in a lot of the hospital decisions around practice, et cetera. So I think also the role of the unit teacher or the CNS, well, I was a unit teacher, now it evolved into a CNS, but in that role, I think that you listen and facilitate. So no question is stupid. If you have a feeling, we should discuss it. Let's go to, if they had say a disagreement with a physician about what they thought was happening. I wanted to, if they had the knowledge and they had put it all together, how do we then approach that physician? And you build your credibility, right, through communication, and respectful communication. So you build it through knowledge and communication. So just working on those.
Can you speak more to that? This is something that comes up in the neuro ICU all the time, is that nursing has concern the patient's somehow different, right? That they're noticing that the exam is not what they've been getting. They express concern. The physician comes to the bedside. The physician walks out and says, "What, the exam's the same for me." And oftentimes what I find is if you fast forward 12 hours or 24 hours, the exam's now different for the physician. The nurse was just the first to pick up on it. And if we would have trusted that instinct, maybe we could have had a better outcome for the patient. How should nurses handle that situation? And how should physicians handle it?
Right. Well, I think, and it's a two-way street, right? So it's always with respect. So that's one thing, is like when you talk to anybody, it's respectful of their position, but it's learning the articulation. So sometimes clinical specialists in my role, as long as they feel, as long as you feel trusted, or you've developed a trusting relationship with nurses would come to me and say, I'll give you a quote, "You won't believe what's happening in that room." Right. Because they know that it's, something's happening, or they're concerned, like you said, a neuro change, and no one's listening to them. How do you articulate that? Why do you think it is? Let's go look at them. Tell me what you see. Then we put it into a package, and then I encourage them to approach with backup. So I might be in the background or something like that. And I have to tell you, sometimes that's a hard thing to learn, because over the years, how that evolved, I think, is just because of our longevity as a neuro ICU, and because I was observing this. I really think, unfortunately, sometimes something happens. Like in the days where, somebody herniates, or somebody has, has been having seizures and static, whatever it might be. I think sometimes physicians learn the hard way, that maybe I should have listened to that, or they learn that nursing has an intricate role in relationship with the patient, which is one of the hallmarks of neuronursing, is getting to know our patients and what they are. So absolutely.
Along with that, I find that the nurses not only know the patient, but they know the patient's family better than anyone else. And they often serve as the primary liaison between the clinical team and the family, almost by default, because they're at the bedside, the family's at the bedside, and they drive a lot of the, I think, impressions of the family. What do you see the nurse's role in speaking to families, and how did you educate your nurses to do so?
Yeah. So, I mean, it's sort of multifaceted, right? So, the hallmark of nursing, honestly, is the relationship between your patient and your family. Like most people that go into nursing because of relationship and wanting to, you also wanting to help or wanting to improve outcome or whatever it may be. But the hallmark of that care is really relationship, you and the patient, you and the family. And by our work in the ICU, we're at the bedside constantly.
Mhm.
So, especially when the way that patient family presence has increased over the years. Now families are in there all the time. Imagine having somebody watch you 20 hours out of a 24-hour day, because they're at the bedside with you. And that was alone was has been challenging. But if you're confident in your practice and you learn how to articulate what's happening with the patient, your other job is also to see and to assess where the family is. What do they understand? So I think unfortunately, I think the role of the nurse at the bedside, and the appreciation for the knowledge that they have sometimes is overlooked when you're trying to look at like what the outcome is, brain death criteria, all of those
Mhm.
things that come into play, understanding, knowledge to go home with, all of those things. I think that I see a movement away from listening to the nurse because the teams have gotten bigger and the nursing role in rounding has somewhat diminished from what it used to be, because of the addition of other players. So I think a wise physician always should ask the nurse what's their family understanding of that. Families tell nurses everything,
Right.
what the situation is, what their understanding is, and it's an important role.
No, I completely agree. And sometimes we will, our fellows will have family meetings or we'll have family meetings with families, and we will think that we are all on the same page. And I always look towards the nursing staff because they're the ones that know, actually, even though you walked out thinking things were totally great, that's not the case. And, this is what's happening. And you need to know about this dynamic in the family because that's playing a large role in some of the difficulties they're having coming to terms with this diagnosis, et cetera.
And Nick, a good strategy for that is, I mean, it's not rocket science. A good strategy for that is to take the time to pre-meet or
Mm-hmm.
meet before your family meetings, before anything sort of formal. Meet with the nurse and say, where do you think they're at? Social work, where do you think they're at? Whoever is involved, where do you think they're at? Because there's nothing worse than walking into a meeting and think you're going in with this purpose and it doesn't go quite the way. And trust is a huge piece of how we interact with families, is building trust and trust relationship in the team. So everybody needs to be on the same page.
Agreed. You mentioned that uh, one of the primary points of nursing was this developing relationships with the patient and their family. And it struck me because during the pandemic, most of us faced critical illness without family presence. And that was the first time in my career I was used to having open ICUs where families, came during all hours and they were always there. And it was the first time I ever took care of patients where I never actually saw a family member. And some, unfortunately, patients even passed without a family member present.
Mhm.
I think that's had a lasting impact on nursing and nursing in critical care. What are your thoughts on that? And, how is this contributing to the loss of nurses at the bedside?
Mhm. I mean, I think it's challenging time, not just COVID, but also there's things like media, social media, that's changed visitation. All of a sudden, neighbors down the street will come into the ICU, and so we struggle with what's private, what
Mm-hmm.
belongs to the patient, privacy, and so we've had, I won't say increased violence, but certainly increases in um, interactions that have not been as pleasant and supportive, which really drains you if you have to always be thinking of things like that, day after day as a nurse. I think there's many challenges. When you talked about COVID, I had just retired, but I did go back to work, and
Of course you did. You're the only, you run towards COVID. Everyone else is running
because
away.
I love neuro.
You go back to work after
Nurses
retirement.
run towards the problem.
Yes, yes.
But what I saw was, I mean, it's sort of, and nurses always make me proud, but it was like, we had a patient who worked at Microsoft, and the family was still in touch with the nurse that took care of them. So she called him, and we immediately got those pads so that you could plug in and see your family member.
Mm-hmm.
And so we used a lot of the technology. And, you know, they came up with solutions for some of those things. But I think what was really bothered most patients was wearing masks all the time, not being able to, you know, really touch, or, you know, all of those things that made it a little bit more impersonal. And then just the exhaustion of, you know, day after day, those types of things, and the unknown of how to care for these patients and all of those things. I think all of those challenges, you know, violence in the workplace, you know, challenges in family care, like I said, just exhaustion, like exhausting time for all of you, not just nursing, but the team itself. I think that if you look at the average age of ICU nurses, it's in the 50s. So I think some of those people that had those challenges are moving towards, you know, end of career.
Yeah.
We're having trouble really recruiting people, which is unfortunate, because there are so many other opportunities available. And also because I think when it comes to nursing, no matter how hard we try, we don't have lots of TV shows that really show what we do. We don't have, you know, a lot of the glory around, you know, how we're making an impact, because
Right.
they're all sort of hidden in patient outcome, like, you know, infection and all of those types of things. But certainly the only way people really understand what a nurse does is if they're being taken care of, or they had a family member who had a nurse that provided them, you know, great care. So it really is challenging. The schools are, you know, there's a shortage in school instructors. There's all those types of things going on. And nurses, I mean, for the work that they do, quite honestly, don't get paid. I'm sure physicians, residents say the same thing. But I mean, when you look at what is being done, it's difficult. So.
Yeah, I completely agree. You mentioned the problems with recruiting new nurses. Yeah, I think we're struggling with that here. We have, you know, bed closures at times because there's just not nurses to staff the patient, you know, the beds. And unfortunately, we have patients who are not able to get into the hospital who need acute care because of it. So it's something we're all thinking a lot about. You mentioned this rotation that you had when you were starting out in the ICU. I don't know that those exist anywhere currently, where, you know, floor neuro nurses spend some time in the ICU. Is that an idea, or are there other ideas to try to grow the pipeline of ICU nurses?
Yeah, I mean, all of these come at a time when also your institution is probably financially struggling. You know, COVID and those types of dilemmas have, you know, hit hospitals financially as well. And there's, you know, it sounds like there's a lot of restructuring going on in some areas. I think, you know, nursing's always the most expensive thing probably that a hospital has to do, to, you know, in terms of budget, etc. But I think that a strategy like that would work. It's just that at the time, you know, in the unit, the roles are different. So in a unit teacher role, and you can certainly do this, but in a unit teacher role, you would need someone who was going to orient that person. And, you know, because if you wanted to turn it over every 6 weeks or whatever it might be, you just have to think about who's going to train them, because the preceptors are exhausted because there's been travelers and everybody else coming. So people that used to precept and love it are tired. And so you would have to just set up a program. I thought it was worthwhile only because I was really afraid of going into an ICU environment. I didn't necessarily think that I was ready, but really what you need to go in a nursing environment is the desire to learn, be patient, family focused, be a team player. And I always told people in orientation, our traditional 12-week orientation for nurses, was the goal of that 12 weeks is not for you to come out being the greatest, neuro ICU nurse that ever lived, or even a functional neuro ICU nurse. The purpose of a orientation is to give you some knowledge about when there's a problem and get help and where to get help. Honestly, that's all you can expect after a 12-week immersion into a neuroscience ICU, I think. So I think meeting people in that 6 weeks would be helpful. I think there's some strategies that we could do to support preceptors a little bit better, so that they could do the work and be more energized by the work, to decrease the numbers, et cetera. So I think there's some model strategies. I mean, maybe you just hire for a short-term period a CNS like Mary Guanci that would come in and just orient people,
Right,
there's some strategies.
Are you on the market, by the way, Mary?
No. But I do think, I think the retiree, I think there's a group of retirees, honestly, that if something came up that was not long-term or whatever, I think we need to just tap in and be really creative about, what we can do.
That's an interesting idea. One of the ways that this is all sort of turned out, I think, somehow related to this concept of burnout that we hear a lot about. And one of the ways that people fight burnout and increase engagement is through opportunities for advancement. And it strikes me that sometimes I feel like our nurses feel stuck a little bit. And so can you describe kind of how, both in your own experience and how you mentored young nurses, how do they advance through the field and get new opportunities and grow so that they're not here for 5 years, but they're here for a long career that's fulfilling?
I mean, there's a number of ways. So like I said, it's really about keeping people engaged, right? So if you're rounding and asking questions at the bedside, if you're giving them support, you're doing a great job. Oh, this patient's family came in the other day, whatever it might be, there's words of support. There's other things to do. Like I said, those committees. So we have a unit-based practice committee that empowers them to use their voice in terms of what's happening. We also have a close relationship and with the physician group, right? So open door policy, all of those things that really encourage, you want to hear what nursing are doing. We started with hiring a while ago. A nurse director, Tara Tehan, invited me to be part of the hiring process for the nurses. So oftentimes it starts at hiring, where you're looking at who are these people, who would they be best matched with preceptor-wise, so that you're setting the environment. So sometimes it starts there. And then there's also opportunities. If there's a few years before I left, because we had the practice committee, we had so many requests to do research within the unit. Well, research within the unit impacts nursing, because nurses are doing the research
Absolutely
at the bedside, right? So one of the things that we asked for was, if you wanted to do research in the ICU, you needed to come to the practice committee and tell us what you were doing, why you were doing it, what was the nursing role. And then the practice committee could opine on whether they would allow that research to happen. Now, most of the time, it's not like a naysay. It's like, how can we make this work? But that empowers the staff nurse, who goes out and tells her colleagues what we're doing and why we're doing it, right? So it gives them a leadership, a role in the leadership, which I think longevity-wise is necessary. I think if physicians who have the power to do so should ask or include a staff nurse at the bedside, on a research
Mhm.
protocol or research thing. So that's another way. We have many conferences. We do coach people to go to those conferences and present posters and things like that. Certainly physician encouragement and coaching around doing that. You have come through programs with many hours of research knowledge and protocol. So you have some of that expertise that perhaps I'm certainly one in my field, one of my least knowledgeable about research. And again, the reason that's important in nursing is because nursing wants to impact patient care. So, and they have a lot of ideas. We had a nurse entrepreneur. So the hospital has an entrepreneurship program. The hospital has a procedure practice committee that nurses sit on. They have, we sit on the donation committee. We sit on different big committees. So nurses are involved in that, which also helps to grow your leaders. Um, there are nurses who do the scheduling for the unit that empowers them to do, there's self-scheduling, which, I mean, people overlook it, but little things like doing preference scheduling where you as the nurse can write in your own schedule and somebody looks at it and you can do your own schedule. You don't have to say I'm working, when I'm working. So there's little things that you can do, and then there's bigger things. But I think the inclusion, one of the reasons that I enjoyed my job was the relationship with the fellows. And those fellows in a dynamic, imagine we did beta test siting for a lot of products. So we did the targeted temperature management beta tests. We did ICP testing. We brought the Moberg in, the integrational device. We brought the Mobergs in and tested it within our ICU. We built 2 new ICUs and did these evolutionary things where we move the patient to the MRI, or the MRI table comes to us, saves time.
What tips do you have for us that are, we're interested in doing these things, and sometimes it can be engaging for the nurses because it's learning something new, and that can be exciting, and they can feel part of the pioneering a new technology, but it's burdensome, it's extra work, right? And so how do you navigate that?
Right. So how you navigate that is really talking about what the outcome might mean to the patient and the family. And also maybe their workload, right? Or maybe how we take care of patients. Just because we work in a dynamic place and we seem to have good outcome doesn't mean it couldn't be better, right? And that's how nurses think as well. So really tap into the patient and why this is important and what this will do. One of my stories that I always think about was a patient of Brian Edlow. Some of you will know Brian Edlow in coma. So Brian Edlow was the fellow, and there was a young man who came in, 19-year-old MVA, very bad head injury, contusions, hemorrhage, went to the OR within 3 hours, had a bilateral hemicraniectomy, piece on one side, whole half on the other, for herniation. We were heading towards, after maximum treatment, all of those things, we were heading towards having a family meeting with his family to talk about, do we trach? What's the outcome? All of those things that nobody wants to go through. Nurse at the bedside, myself, very involved because of the family dynamic and all of those things, family support, and Brian. And it's a devastating thing for the whole team, right? Everybody's not wanting to go this way.
Absolutely. Always heightened when it's a young patient too.
But MRI at the time was doing experimental work, looking at tracks. And so the advent of looking at an MRI and looking at tractometry and those things changed the course of our conversation. We happened to send him for, we negotiated, our nurse talking, why do we have to travel to MRI? How can we travel with him? He's so devastated. Can we travel? Should we travel? Got the MRI. We talked to the researchers who came in and redid the MRI machine so we could use this new technology. And we saw this 1 or 2 track. That one track was available to this kid. This kid, 5 years later, still talked to his family, still involved. He is almost 10 years later, sorry. He is fully functional, speech, everything, bowling, hanging out with his friends, holding down a job. He's a coach at a high school. Unbelievable, unbelievable. You would never have thought that we swung, but because of the technology and the research, to me, it just kind of made me feel like we were on the right track in terms of trying to do as much research and really move the practice as much as we can. So I use that story all the time to support the need to work together.
Yeah, no, that's a fantastic story. And, Brian is obviously playing a large role in the Curing Coma campaign through NCS, and this is what it's really all about. Mm-hmm. I'm wondering, you mentioned tractography and, Brian's work kind of in cognitive motor dissociation and us learning that some of these patients are actually aware in the ICU. What breakthroughs did you see in your career that were really game changing, and what breakthroughs are you waiting for? Things that we really need, from the nursing perspective in particular, to move our field forward.
Great question. So I obviously have seen everything that would be considered every day now, but I talked about CAT scan. Mm-hmm. I talked about MRI. How MRI came into play. So those 2 things changed how we look and evaluate patients and some of the decision-making that we were making around that. I think of, the changes in care. A subarachnoid hemorrhage came in 1977. If a subarachnoid hemorrhage from an aneurysm came in, they would be 3 weeks in a dark room, no stimulation, nobody visiting. Then they would get clipped if they made it without going into stent.
Right.
That was truly how we were working. So if you think about how we've evolved to early clipping, how that evolved to neurointerventional procedures, and we hardly go to the OR with subarachnoid hemorrhages anymore. There's smaller, well, I would say smaller, vasospasm work, like I mentioned. If you think about all different types of things, to nursing, we've always mobilized patients. So I always laugh whenever I say, should I mobilize somebody? Within 24 hours, you're out of bed in the neuro ICU, mm-hmm. Always have been. But some of those nursing strategies, infectious, just different monitoring. I really like the thought of the Moberg, because I know there's a lot of controversy still about ICP monitoring, and we have EEG monitoring that's evolved, but I really like the integration at the bedside of getting all those numbers and seeing what the relationship is between nursing care and some of those things. So I think in the future, it's more looking at the integration of information, but always at the center of that is the exam. So no matter what, it all comes back to the exam and the nurse at the bedside.
Yeah, it all comes back to C. Miller Fisher, I think.
No, it all comes back to nurse at the bedside doing an exam.
Right.
With C. Miller Fisher's help.
Of course. Well, I think we're coming to the end of our time here. We have kind of some quick hit questions that we ask all the guests on the podcast, and just to get a little bit to know you better. And so what did you do, and what do you do outside of the neuro ICU as a hobby or passion? What excites you outside of your day-to-day work?
Gosh, a lot of things. Quite frankly, the family, because you spend so much time, sometimes I, spend a lot of time and emotion in the hospital, like coming home to your family. And so really family. I have grandchildren. I actually do golf. I took up some golf, do something physical. I like to to keep active if I can, keep the mind active. So those are some of the bigger things.
And if you didn't end up in the neuro ICU, what other specialty would you have liked to have attempted?
God help us. I don't know. Like I said, from early on, I was fascinated by the brain. And I think that, that's obviously where some of the passion comes. I've, been able to keep it going. But I know one time I did think about transplant, and it was just, I think, because sometimes you see so much death and dying, which we haven't addressed here, but for nursing, that's definitely something that takes a toll on neuroscience nursing, especially. But I had, it's just overwhelming at times. And I thought, well, and then we were doing a lot of organ donation, et cetera. And I thought, well, I'd like to go to transplant, because at least in transplant, it might be more upbeat, because they're getting something that is going to improve, their lives. And I certainly have a connection knowing where their donors may be coming from. So I thought I considered transplant for a while, but.
Right. Let's take just a minute to talk about the death and dying, because I think we did overlook it a little bit. And, it struck me as you were describing the case that where Brian Edlow was the attending. I think I actually saw a video that MGH did maybe on that case or similar one thereof. And that's sort of unique. We don't necessarily share our stories, at least in a video or recorded way that is widely distributed so that people can see our successes. How important is that to neurocritical care and to nursing? And how do we share the good outcomes? Because often those good outcomes don't happen in the ICU, right? It takes time. Yeah. And sometimes I feel bad because our nurses don't get to see that all of their hard work actually was worth it and did lead to a life worth living.
Yeah. So there's some strategies we've used over the years. Our physicians, if they saw somebody outpatient, would encourage them to come back to the ICU to visit. So we were getting, visits from patients, as sometimes we would anyway, but certainly when a patient and family comes back, that was one strategy. We debrief quite a bit, which is a great strategy in terms of, I would walk around and sometimes it would just be, wow, this place is crazy today. And we would call come to the back room. We're going to debrief for 5 minutes. How's it going? What can we do? And regroup, like the debriefings after a particularly challenging, for some reason, could be any kind of challenge, a challenging case, either with the nursing staff, but with the whole team. Almost like post-arrest debriefs that people do, they pause. We have had, care sessions with chaplaincy coming to chat, just 5 minutes. Because if you want to do more than 5 or 10 minutes on a unit, that might be problematic for the nursing staff. So, short, but those things really do make a difference. And then I do think that we need to share our stories more. I'm not sure where or how. Sometimes you lose some of the passion or the emotion, but we need to share stories with each other a little bit more, because we're all in the same place. So if you take care of neuro ICU patients, there's been times when you've been elated. There's been times when you've gone home worn out. So
yeah. You see these videos of oncology patients at a lot of centers, they ring a bell or they have some way of showing that sort of they've beat cancer, right? And we don't have an equivalent in neurocritical care of ringing the bell. And right. I think we need to figure this out for everyone's sake, because it is so uplifting to see that moment.
Yeah. And sometimes the outcomes, I think people that work outpatient could really, if we could connect, because the outcomes that they see, we never see, right?
Right.
You might see them, but nurses certainly in ICUs don't see them. So we have conferences sometimes, and I invite a patient to come speak. So that's another uplifting way you can, have the patient, present or tape their story. So.
Great. Okay. Is there a sound or a smell that you just really miss from the ICU that you look back on fondly?
Well, smell, I'm going to say no. I'm going to pass on the smell because we all know what nurses smell. And then I think the sound is honestly laughter, because laughter means we're having a good day, that people are managing and everything's going. So we would hear people joke, laugh. Do you want to go to lunch is also a good sentence to hear, because that means there's time.
Yeah, that's a good day.
Yeah, that's a good day.
And then I guess you alluded to this, but is there a sound or smell from the ICU that you just hated and you're glad to have put in your history?
Yeah, well, I couldn't, I could live without the smells of caring for patients, but the probably the what was the rest of it? Just bad smell. Sound, taste.
Yeah.
Yeah.
Ironically, I think Alan Roper said that he missed the smell of Melena.
Yeah, you can't miss that.
I agree.
Well, obviously, that's the difference between a nurse at the bedside.
Yeah, because he got to go away from it, right?
Yeah, and a physician. I don't know if he smelled it, it's because he walked in
and walked out and let you know
that
about it. Yeah. And then lastly, as we wrap up, what advice would you give to new neuro ICU nurses as they embark on their careers?
Oh gosh, I think just I just think to be open to experience. I think to really embrace, patient family care. I think to learn how to or empower yourself in some way, whether it has to be through education or ask questions. Take care of yourself. Make sure that you're have exercise routines or some way to debrief, or sometime to relax, whether it be at home or whatever it might be, because it can be a very empowering, exciting environment, and you can feel that you've really you feel like you have really given something and made and improved outcomes for our patients. But with that may come the price of to yourself. So really, spend some time talking to your colleagues, debriefing, and again, doing what you can to keep yourself well.
And then to wrap things up, my boss, Neeraj Bajadia, has told me that in his estimation, you have trained more neurointensivists than anyone else in the country. So what advice do you have for the fellows? How should they approach their interactions with nursing staff, and how can they be successful in their careers?
Oh, gosh. Well, it is true. I probably have. Neeraj was one of them, or we cracked the whip. But I think the biggest thing for a fellow, we've talked about it a lot, is really like open communication. I think that like we talked about an exam, if a nurse comes and says something's not right, it is good to acknowledge and to find out and really have a conversation about patient family care. If you are, what nurses are doing are trying to deliver the best care, just like you are. And hopefully you are also acknowledging their practice and skill as well. And together you'll make a great team.
Great. Well, thank you, Mary, so much. This has been incredibly informative, and I think a really valuable contribution to our membership to learn a lot more about what nursing in the neuro ICU is all about, and how we can foster relationships with the physician nursing dyads and keep nurses engaged throughout their career. So thanks so much for joining us. And this is Nick Morris signing off for the Neurocritical Care podcast.
Thanks, Nick.
All right. That was great.
I don't know.
Wonderful.
I kind of screwed it up at the end there, but well,
no. I think it was fantastic.
I don't know. I don't know. All right.
No, that was really, really good. I hope it wasn't too bad for you.
It wasn't bad at all. I will say, one thing about neurocritical care that you asked me this question, but we don't have to put it on. But one thing about Neurocritical Care Society that I'm kind of a little bit concerned about is, and you've alluded to that, the staff nurse has not a lot of time to, go to attend meetings. They've taken away some of the financial support for that from nursing,
Right.
certainly over the past couple of years. But I wouldn't want neurocritical care, even though APP's important role, it's a very different role than a nurse at the bedside. And I would hate for, neurocritical care to move away from, recruiting bedside nurses. So
Yep.
I'm wondering, I'm sure that's on the nursing. I know
Yeah,
that
this is a
I
big
know that
problem.
Sarah has this all wrapped up, but I do worry.
It's a problem. I don't know.
Yeah.
I just heard, so our lead APP is on the board of directors, and she was telling me that they cannot fill a spot on the board of directors with a nurse right now. They haven't had anyone self-nominate. And it's the first time.
Me feel guilty because they asked, but I couldn't do it I couldn't get this paperwork in at the time, and I just finished the neuro on the other one, so I'm like, oh, I need a break.
Yeah, but it's getting to something, right? Which is that it's been hard, I think, for the society to really engage with the bedside nurses and to make them feel part of things. And I think you're right, is spot on. It's the problem is like, even like my budget for travel and things, if I'm not speaking, it's never changed. So with all of the increase in cost of living over the last 7 years, I have the same budget, and I'm running out of money to go to conferences and things a lot faster than I used to. And we're privileged as attendings that we have more discretionary income. Right. But I understand that you can't go to a conference now for less than $2,500 or $3,000.
It's tough. But I don't know, like if this program like Bring a Nurse, or I know there's scholarship money for some of it, like travel and stuff like that. But it's just it's something that I hate to lose. Like I'm obviously a big bedside nurse person, advocate. I hate to lose that voice, especially in like the research. I was on the research committee at NCC for a while. It's a pretty dynamic committee, but when you're doing your PICO questions, there's not a lot of like nurse at the bedside type question. That
I think it's so important. I mean, some of the studies we've done here, like we did the Intrepid trial, with it's Dave Greer and Kevin Sheff.
I was in that.
You were, right? You were part of that. And that was so hard on the nurses. I mean,
it was.
We were one of the top enrolling sites, and I mean, I feel like I nearly broke some of our nurses because it was so much work.
It's a lot of work, and that's the thing. Like I said to Dave, because we did the protocol and all. I said, this is going to be so hard for the nurses. What are you going to do for the nurses? But interestingly enough, Nick, when we were writing things up and doing things, I had to say to them, you realize how much work these nurses around the world have done on this protocol? Can you at least acknowledge? Like, it's simple, but can you at least write and then they said, well, some of the journals won't take that. I'm like, well, we need to address if they're going to delete something that says they acknowledge the work of the nurse, because otherwise nurses, are not going to support research at the unit. Like, it's like, no,
I can't imagine a more labor intensive trial for nurses.
That was so labor intensive.
It was.
But we got an outcome. Not the one we wanted, but we got one.
Yeah. And then we didn't get to I think the APP story is interesting, right? Because unfortunately we see so many, this is good and bad. Some of our best APPs were our nurses but the nursing stay in the ICU was just like a way to get to the NP degree and join us.
And that's okay, because you need that. You want to have those skills, right? Also incorporate an APP. For me, I think the APP role sometimes, instead of leaning towards nursing, it leans towards sort of more of a medical model. So The nurses feel like their voices, even nurses at the bedside feel their voices even lessened because that APP takes on, say in rounds, they take on a role in rounds that the nurse at the bedside used to do. I don't know if that was happening when you were there, but we used to present the patient, you know, and so all these other people in the team have taken a little piece of that role. So the voice of the bedside nurse is minimized. But anyway,
I see that. And interestingly, in our unit at times, you know, it used to be that I think there was a little more tension sometimes around the neurosurgery team in the morning. You know, they're telling me this is changed and I'm telling them it's not changed, or vice versa. Now it's the APPs and the nurses who tend to butt heads a little bit more.
That's what we're saying. I mean, I just think it's because our nurses are so empowered, as you've talked. I mean, they, you know, they see a problem, they certainly can bring it forward. They feel empowered to, you know, advocate for their patients and their families. And that becomes a problem because then there's family meetings with the APP taken, not taking the nurse. And it's like, but you're a nurse. Shouldn't you know to take the nurse?
No, totally.
So we have that kind of sort of that shuffling and reshuffling of the APP role. I mean, I admire them both, but it's just it's just pain.
I think we still haven't totally figured out how to integrate APPs into neurocritical care units. And we're having the same problem with APPs, is that they come for a couple of years and then they move on to sort of, you know, jobs where they don't have to work nights and weekends. And they're looking.
It all gets back to motivation and what motivates you. So if you like neuro and you like patient family, you know, intervention, then you're going to focus yourself on that through education and relationship building. So you know, you can't make everybody lost. No. I don't know. I feel like a dinosaur sometimes because because the average age is in the 50s, 60s, but
I would say the average age in our unit, I mean, I feel very old now as a 42-year-old.
It's definitely flipped since COVID.
We our average nursing age is probably 28. I mean, 27. And that's because we've got some outliers, you know, at the 50, 60, but we have the vast majority of our nurses have graduated within the past couple of years.
Which we used to be. So, I mean, if you think about it, as long as you're empowering them and you're making them feel part of the process and, you know, they're getting support and all of those things, then hopefully they'll stay till they're 50.
Yeah, I hope so. The problem is I think also even, you know, our charge nurses are sometimes 2 years out from school. And sometimes when the bedside nurse is looking for backup and you have a charge nurse who's not so confident themselves.
Yeah, those are all tough.
And it's tough.
Yeah, I'm hearing it's tough. We're a little bit more fortunate just because our unit has still many older practicing nurses, but they'll turn over soon because it's
inevitable.
We have to get more nurses. Be nice to Nurse Week.
We do.
All right.
Well, I don't want to take your whole day, so thank you so much.
All right. Well, tell Neeraj I said hello.
I will. I'll see him today. I'll tell him to say hi.
I appreciate his comments about me, but they gave me a big picture when I retired with all the pictures of everybody who came through. It was big. I don't know what to do with the picture now. I'm like, you really think in retirement I'm going to sit and stare at them all day?
That's funny.
Yeah, I appreciate it. You guys. I mean, you guys help shape the unit. So,
well, thank you. I was just there briefly because I didn't stay on for fellowship. So I'm
more to come. There's more changes to come. I'm so excited to hear about what's going to happen with, you know, certain patient populations. So I think it'll be great.
Me too.
I'll keep in touch.
All right. Thanks. I hope things like this will get people more excited about nursing, and we're trying to put things out there on the podcast, at least, that will engage, you know, people with NCS a little bit more. So hopefully this plays a small role in having someone decide to come to the meeting or something that, you know,
I think I think you hit on it when you said to tell stories in a collaborative way, and you know, all of those kinds of things. Like I think there should be more at the conferences. There could be more collaborative care. So there's a presentation, and then there's, you know, the nurse, you know, and you kind of you do it together. So it
Mhm,
shows,
mhm.
you know, the teamwork. And so that really helps to also elevate, you know, nurses in terms of like, you know, sort of highlighting their practice. So you don't have to come through the neuro ICU and get beaten by Mary. Oh no, we're not doing that today. Why do you want to do that?
Yeah. I actually didn't ask that question. I had a question there that I remember that were you a stickler for something like, oh, why do you want to do that?
Yeah,
Like,
why do you want to do that?
would
Well,
Mary
it
let
was,
you do that?
I just think it's like, again, I always tell them, like, if you know, like, you have to read studies. And so like people, because you guys talk in study speak.
Yeah.
So if you'll write full of study and say, I'm not doing that because this happened and
Oh,
whatever.
yeah.
And we'll go, well, we're not going to do that because on this research
Yeah. Or you have
protocol,
to know,
this happened.
actually, you can't
And
apply
it's like
that
a
study to this
stalemate.
patient because that's not who the study studied. They studied
Right.
different patients. So
Right.
yeah.
So you have to do it. I mean, you
Yeah.
know, but anyway, all
All
for
right.
the greater good.
Well, have
Good
a
to
lovely
see you.
afternoon. Thanks so
All
much.
right. Take
Usually
care.
these take a few weeks to get up.
Oh, I can't imagine what it sounds like.
It'll be great.
No, I don't think I even hit my important points, but that's okay.
No. I think we got to the main ones.
All right.
Yeah.
All right. Take
All right.
care.
Take
Bonnie,
care.
nice to meet you. Bye-bye.